I have no conflicts of interest to declare. So what is it about dementia and people living with dementia? So the who and the why part. People living with dementia stay in hospital twice as long, and during the hospitalization, they have more adverse outcomes such as delirium and falls. So these people who have the condition, the extra condition of dementia, don't fare as well in our acute care hospital systems. Here's another slide that illustrates it a little further. They have longer hospital stays. So you see persons living with dementia, 8 days compared to 4 days if they are 65 to 79. And if they're older than 80 years old, 8 days versus 6 days. And they have these people that have dementia and require acute hospital stays have greater harms from more iatrogenesis. So again, restraints, both chemical and physical, and urinary infections, pneumonias, hospital-acquired pneumonias, and falls. So those are sort of the big three that end up being more common in people who have dementia. So this slide is what I call the proverbial elephant in the hospital. And it's based on the parable of the elephant, and the elephant is being examined by 6 people who are visually impaired. So all they can do is to feel parts of the elephant and try and describe what that object in front of them is. So you have these individuals and their tactile perception of this large animal. So one person feels the trunk and they feel that it is representing a snake. Another person feels the large flappy ears and says, oh, this must be a carpet. A third individual feels the pointy tusk and says, oh, I know this is a part of a spear. Fourth individual feels the legs and says, I'm feeling the trunk of a tree. Another one feels the side of the elephant and says, I am perceiving a wall. And the last individual is able to detect the tail and it says something totally different there. So all the healthcare workers in a hospital, which is a very large and complex organization and institution, see different parts of the whole, persons living with dementia. So I've also tagged other aspects that different healthcare individuals can perceive as these people living with dementia. They are driving sitter costs, they have agitated behaviors, they are impacting on emergency room capacity, they're commonly turned into alternate level of care, and they have more post-op complications. And lastly, poor patient experience, because the delirious person who's having verbal and physical aggressive behavior can also impact on their roommates, because we have multi-bedded rooms at the moment. So what can we do about the who and the why? Well, like I said, we had a deep think at the beginning of the COVID pandemic, and the Regional Geriatric Program of Eastern Ontario looked at this problem and contracted with a dementia specialist in Ottawa to really review the situation and to develop a dementia strategy for the acute care hospital. So how was this done? It was a process that required and involved a world literature review as to what the status was. Were there any acute care dementia strategies out there that have been published? What people's experiences were? stakeholder consultations. So that means the caregivers themselves, the staff in the hospitals in various services, both medicine and surgery. So there were focus group sessions, there were surveys, there were questionnaires, etc. And a small group of us at the hospital met with the dementia specialist, and we had virtually met, because that was the way we had meetings for the past 2.5, 3 years, iterative meetings that lasted for 6 months during the time span of January to June 2021. Here's some of the input data. So some of the squares show the review articles that were found and read. There was a discussion paper published by Ontario Ministry of Health. There was a booklet produced by a group in Vancouver, BC. And there was yet a much more local document that was produced by the previously known Champlain Lynn on a dementia strategy for the Champlain region. So the colored squares, you find a word salad of some of the outcomes or the outputs of the focus groups that the dementia specialists had with carers. So scary, frustrating, confusing, slow, hard, fearful. Those were kind of the words that came out of their focus group. And likewise, a focus group sessions with frontline staff. You see those words in their word salad. And again, the larger the word, the more frequent it was mentioned in those focus groups. So rushed, frustrating, challenging, demoralizing, insufficient resources, poorly resourced, all those kinds of comments. So with that input and discussion and iterations, what was the result? A document was put together, went through several draft versions, and finally came to the final version, Dementia by Design, an Acute Care Dementia Strategy for the Ottawa Hospital. And in terms of giving you a sense of the metrics, I really consider this document, or I call it the Encyclopedia Dementia, because it is a one-stop reference document. It's something that you would really want on a bookshelf, and you pull down for snippets and paragraphs. You would not want to read this unless you have insomnia. It's 37 pages long. It's got close to 14,000 words in it, and 700 paragraphs, 5 chapters, and 24 references. And again, it laid out a strategy for improving the care of persons living with dementia who need to be in an acute care hospital. So again, the vision of having this document produced for the Ottawa Hospital and sponsored by the Regional Geriatric Program of Eastern Ontario is to strengthen a system of dementia care that reflects the hospital's vision, mission, and strategic goals. So that sounds really, really good. But in addition to that, we wanted TOH to be recognized for the world-class care, but specifically to improve it for care of persons living with dementia. We want to also be mindful of the quadruple aims of healthcare, so decreasing length of stay, so giving more value for the money being spent for acute care services, improve the outcomes and patient-centered care for those living with dementia, improve staff well-being, optimize the healthcare system resources, and be proactive and preventative. So all the good stuff mentioned within the strategic document. We found, as we discussed further with our colleagues and around the hospital itself, that the acute care dementia strategy had synergies with existing initiatives at TOH. And here are some of them that were listed, that there was an ongoing ALC strategy, what to do with the 250 plus ALC patients that are in TOH on a daily basis, especially when services restarted after a lull with the initial phase in the COVID pandemic. It definitely interdigitated very nicely with the TOH delirium policy. The emerging personhood focus on individualized care at TOH. There's a focus on integrating the electronic care plan into our current electronic medical records so that it is easily shareable amongst different healthcare professionals as they take over from shift to shift. And emerging efforts in critical illness conversations and end of life. Because again, persons living with dementia, as they progress from mild to moderate to severe, should be afforded these important conversations and decision making and goals of care. So now you've heard about who and why and what. For a peek under the hood, what are the components in the dementia care strategy? Here's a partial listing. So we require hospital level data to make decisions on. We need strong leadership and corporate commitment because it is a change management project of immense proportions. We need to be able to detect this condition called dementia and document it properly. As I had illustrated with the elephant analogy, different people are seeing different parts of the whole, and we want to bring that back to the whole and say, that agitated person who you have the sitter next to, that's a case of dementia, delirium with dementia. So the more that we are able to document and sensitize, the better things will be for all patients living with dementia coming to the acute care hospital. We need to value and support families as their essential care partners. We need to continue to support person-centered individualized care. And there are special approaches for persons living with dementia that work compared to other approaches that leave both the patients at risk for adverse events, the families frustrated, and the staff clearly dissatisfied with what they're doing. So staff education and support are definitely vital. Dementia care expertise that is brought into the hospital to train the trainers and to increase capacity. We need to develop a nice toolkit of non-pharmacologic approaches to behaviors and to standardize it so that it is available to all staff, including transport people, ward clerks, volunteers, everybody, because the dementia, the persons living with dementia will be everywhere. They may be in the hospital visiting somebody else. Individualized proactive discharge planning, sort of a variant of person-centered care and or individualized care. And we need to make sure that there is a supportive and adapted physical environment. So in fact, there is strong thinking and lots of effort being placed into the current new civic hospital development to make sure that it is dementia aware so that people can wayfind, can be comfortable coming into this brand new shiny building and not get anxious about what it is and where they need to go to complete their task. So you've seen a little bit about the acute care dementia strategy, why we're doing it, who's affected. It's really everybody in the hospital, patients and staff. So when is this going to happen? And I'd have to say it is happening now. We have to move on it now. And next question is, how is it going to be done? Because like I said, this is an enormous change management project. So the next little while, I'm going to describe to you some of the work groups and where we are at and where we want to go from here on into the future. And the future is 1 year to 10 years forward, because it will take a long time to get everything done so that we meet our original vision. So this is a schematic of the organizational structure. We have the top hospital executive leadership, and it sponsors a TOH Dementia Strategy Steering Committee, of which Laura Wilding and I are co-chairs, and we oversee several working groups, of which there are 4 named, but 3 operational at this moment in time. And it's a continually moving target, because we see opportunities and perhaps we see challenges in other areas. So we have to adapt to the ever-changing hospital environment to move change forward little steps at a time. So the 3 major working groups right now are the documentation and data, building staff capacity and process optimization, and caregiver experience, transitions in care, and community partnerships. And underlying that and foundational to that is an evaluation framework that crosses all these work groups and includes also a corporate communication strategy, because again, trying to change people's thinking and behavior, we need to communicate frequently and truthfully and using data-driven decision. So just to give you a flavor of what's happening in each of the work groups, the documentation and data, this group wants to identify patients, people living with dementia using the electronic record, and to improve the hit rate and recording rate of that. So there are efforts in terms of educating the users to document dementia wherever possible, so that we can improve the identification. And once we're getting better at that, to implement a hospital scorecard for dementia, because again, if you did the back of the envelope calculations, if you have 1,000 people in hospital today at TOH, and based on demographics, actually demographics probably doesn't drive hospitalizations, it's really acute illness. So at least 70% of TOH inpatient population are over the age of 65 today. So that's 700 people in hospital over the age of 65. And a fair chunk of them are over the age of 90. And if you took a room full of 90-year-olds and you sit them in rows, and you take one of those 90-year-olds and you ask them to look to their left and look to their right, well, one of those 3 90-year-olds is demented, because that is the current prevalence of dementia in 90-year-olds. It's about 30%. So if you have 700 people at TOH hospitalized today, and perhaps a good 50 of them are over the age of 90, then a third of those people have dementia. So there's a fairly significant number of people with dementia in hospital today, causing grief because they are agitated and delirious, because they are wandering and they're intrusive, all sorts of things. And there are falls happening. There are medications that are misused. There are sitters trying to identify risky situations. So it's happening today in many places. The next work group is building staff capacity and process optimization. And it's doing a lot of work as to what is the current state of care for everybody in TOH, but specifically, how can we change these processes and the knowledge and skills of the healthcare workers that have to deal with persons living with dementia that require acute care. So I've mentioned these three squares that you see on the screen: input from the dementia strategy, utilization of care pathway, mapping out current care processes, identification of opportunities, and input. Well, actually, that's duplicated. Sorry. There was another point that I guess didn't get copy and pasted over properly. But to boil this down to exactly what's happening, here's what a little more detail, which shows the complexity of what the dementia strategy is trying to do. So here you see a preliminary, it's more than preliminary, it's gone through several iterations, the dementia care pathway. And so what is happening to people living with dementia when they are admitted? So these are all the various components that have been identified. And within each of these items that you see on screen, there are further drill downs into how things are working, where modifications can be attempted, and how do we implement all these changes. The third working group, equally important, is the caregiver experience, transitions in care, and community partnerships. And again, the goals of this working group is to develop and implement initiatives to increase early engagement with patients and their care partners, to increase proactive and timely transitions. So that's both ways, so bidirectional into hospital, which you may think, well, that doesn't make any sense. Why would you do that? Well, if you catch something early, stabilize it, you may actually create a shorter length of stay than if you caught it late and you had complications. And of course, timely transitions out of hospital with adequate home support. Build capacity for patients and care partners, again, education support, and the use of what's called a dementia navigator technology. That's somebody who knows how the system works for patients, people with dementia. Enhance partnerships with community and the long-term care sector to facilitate person-centered, timely transitions. So again, just-in-time transitions would be optimal, if at all possible. And again, using different technologies and approaches would certainly help that along. Here's again another slide that shows some of the detail that exists when you start drilling down into improving care. So patient and caregiver experience, transitions, and community partner engagement. I've just inventoried several of the items that are being looked at, and again, further drill down to details and implementation in time. One interesting resource that I'd like to highlight is the development of a dementia strategy nurse educator role, because the acute care dementia strategy implementation and the committees and the teams are all made up of people who already have day jobs, and much of this work is volunteer, unpaid, and we certainly, the individuals can certainly not be asked to implement the change because we have everything else that we're doing. So this would be a new resource that the hospital would need to invest in, and we're closing in on that investment commitment to be a person that will help lead, develop, enable, sustain, and expand the education role. And again, you see some of the tasks that are involved in this person's job: leading dementia champion rollout, develop curriculum, enable the champions to support frontline staff, and sustain and expand the dementia program with other initiatives, both within and outside the hospital. And the fourth work group, the end of life care, is currently under construction, because we recognize that this is an important part of people living with dementia that end up in the acute care hospital, especially if they have an acute condition on top of a moderate or severe dementia. They need to know all options as to what can and can't be done in terms of supporting the ongoing quality of life rather than just prolonging life. Because medical technology, anesthesia care can actually get almost anybody through almost any intervention alive. But is that something we should do, even though we can do it? So this again is another important area that is starting its exploration and initial discussions. So you heard about the who and the why, what we're doing, how we're doing. Where do we go from here? And where are we today? We've had the acute care dementia strategy committee launched and working. It was launched about a year ago, working in earnest for now probably 6 months, starting to get traction in terms of where we want the change management to occur and the implementation. So there's lots of work to be done inside, but there's also lots of work to be done outside of TOH. So we need to continue to improve and expand partnerships amongst our geriatric psychiatry colleagues and the family medicine care of the elderly, because a lot of the dementia patients are out there in the community. So we need to understand where they are and what their status is. There are other acute care hospitals in the Ottawa and the region, and so we would certainly be happy to share the acute care dementia strategy with others to see how they would want to implement parts of it. I mean, share our encyclopedia dementia. Community awareness and outreach. There already exists in many long-term care institutions the nurse-led outreach teams for behavior management. And we need to make sure that our network reaches out and develops with all those services. And the nurse-led outreach teams are also managed by the Regional Geriatric Program of Eastern Ontario. So that certainly helps ground the organizational structure and makes it easy to catalyze change. I think we need to develop networks of excellence because different institutions and areas will want to take a different chunk of the pie, and we will learn from those experiences. And certainly we want to continue to inform the Ontario health teams as they build for the future, and the Provincial Geriatric Leadership Ontario office, which helps try and provide guidance in standardizing care for older adults across the province. And there you have an overview of the acute care dementia strategy. Lots of time to answer questions, to gather comments, and see how people react.
Thank you so much. And just a reminder, you can put your questions in the Q&A and or post them in the chat. People are finding your presentation informative and inspirational, so that's excellent. Maybe I will kick things off. I'm going to ask a question, Alan. So we've had snippets of this for a long time. We've had policies around older adults. We've done initiatives. We've done Move On. We've had different delirium type of activities. How is this different, or what maybe has been the challenge with making that stick in the past?
I think in the past we had a very diffuse branding and communication framework for geriatric medicine as a whole. And it was very confusing to people. Well, what is geriatric medicine? What are we specialists at? And we never had a very good message. And I think that one of the catalysts was the arrival or invention of the geriatric 5Ms, where we said geriatric medicine are experts at, but not limited to, things that deal with the mind, mobility, medications, multi-complexity, and what matters most. And so since we've projected that framework and said, okay, dementia represents mind, dementia. Okay, it's not only that, but mind is dementia, delirium, depression, all these things with the mentation, so that we could hang our communication onto something. And so people start to get that with the geriatric 5Ms framework. So in fact, if you look at the content of the RGP education series this year, it's focused on the mind. So it might seem to be single tracked, but nothing wrong with that, because dementia is a big problem. It's hidden. And I think that the more that we communicate that message out and people get it, that if there's a little bit of understanding, it will just help get better understanding in time. So maybe that's why it's sticking.
Yeah, absolutely. It's that job of marketing ourselves, and using that platform of the 5Ms has been extremely helpful. So we do have a question. Does the document include any recommendations for acute care medical staff about when and how to discuss dementia with families, particularly when the patient has new functional losses?
The document itself does not dive into that great a detail, but I think that it's going to be along a spectrum of things that we will discover as we start to implement little by little. If you look at our own geriatric medicine unit, the disclosure of dementia is on our must-do list for people who are coming through our unit. Well, because that's part of the 5Ms. We have to disclose their mobility, their medications, and their dementia. On other services, for instance, if a person came in with abdominal pain and eventually has a diagnosis of a mild dementia underneath that, who's supposed to be disclosing that? Is it the surgeon who took out the gallbladder, or is it somebody else? More often, I would say the geriatric medicine consult team can be engaged with that discussion, and we can put that in, or we can eventually send in the dementia navigator to help educate and inform the patients and their families. So it's sort of wide open. We haven't been prescriptive because, again, the strategy is not meant to be that. And we may be exploring different ways of doing these things in different contexts.
Yeah, and just to add to that too, I think the other place where we have opportunity, or we've talked about it, is with that work. We call it end of life, but really that encompasses some advanced care planning, advanced care planning, critical conversations, and that's the other place that helping support staff to feel they have the resources. So, excellent question. I don't know if Angel has a question. There's a partial question type there. And nothing else. Okay. There we go. Thank you for the informative talk. How, if at all, are comprehensive cognitive assessments, including feedbacks, integrated into this dementia strategy?
Well, the diagnosis of dementia is not to be done lightly. Firstly, we have to make sure that there's enough knowledge and skill to separate out dementia and delirium, because delirium is a temporary condition and dementia is a persistent one. And again, also depression. So it's a dilemma that you have an agitated person and what's happening, what is causing what. So the dementia strategy is detection of dementia. It comes with its diagnostic criteria, etc. So that do we intend to create geriatric medicine specialists and geriatric nursing specialists out of everyone in TOH? No. I think we need to set about a system that the check engine light comes on an individual that needs a sitter, that needs sedative medication, that there is a suspicion of something going on. So if the check engine light is on, then you ask the specialist, well, what's wrong with this engine? And so that's where the geriatric medicine consult service comes in. And it's now integrated with the behavior management services with our geriatric psychiatry colleagues. So it's one-stop shop. And we will help clarify what's going on. We will help link in the services required, the dementia navigator and or the dementia coach, so that in time, through a process of more of osmosis, people do pick up these things to say, yeah, that pattern looks like somebody who's delirious, but maybe they are demented underneath, and maybe I'll get through some screening questions later on or ask for collateral information from their care, etc. So we just build those skills slowly but progressively, and build on top of our successes.
And I think you've hit the nail on the head. It's addressing that elephant in the room, right? And actually bringing it to the table and talking about it the way we do other chronic health conditions. And so I think that really is what it's about, is building that awareness that this is a significant chronic illness. So that's where we hope to go. Last call for questions or comments. Consultation to neuropsychology addresses some of these issues, as well as communication of diagnosis. So really just commenting that, again, on the role of our interprofessional team in diagnosing dementia. So that's from Dr. Della Malva. Oh,
absolutely. But unfortunately, neuropsychologists are even a rarer entity than geriatricians. We need to clone them.
And that speaks to building system capacity, really, when you look at the number of people that we're trying to bring to the table and engage, all the way from primary care to all of our interprofessional team that's involved in the care that we provide, plus our geriatricians. We need to build system capacity to sort of accommodate the number of individuals that we're supporting. We've also, and that of course includes our geriatric NPs. So adding geriatric nurse practitioners to providing assessments could help, was another comment.
Absolutely.
All right. Well, I think that brings us to the end. We're finishing a few minutes short, but I wanted to thank you, Alan, for your wonderful presentation today. We've got more exciting events coming up. You can see our education series and our geriatric rounds. The next rounds are at the end of October. You can find out more information about all that we do to support you from an educational perspective on our RGP website. So please have a look. Thank you again, Alan, and thank you all for joining us today. I hope you have a wonderful day.